Hello again, everybody. My name is Marty Guthmiller, and I am CEO at Orange City Area Health System. And you can tell by the screen today that I have an all-star panel assembled. Our Dr. Alan Laird, our Chief Medical Officer, and clinical pharmacists, Amy Van Gorp and Randi Sayles. So I'm going to let these guys introduce themselves in just a little bit. I wanted to talk about a couple topics before we get into our primary subject matter of the day. The first one was regarding the federal mandate that was issued or announced last Thursday by President Biden regarding not only vaccinating all employee groups over 100, but more importantly to us in healthcare, all healthcare facility employees as well. Those details yet are very unclear, and so we're just kind of playing it day by day at this point. We have not mandated vaccinations for our employees yet. We will, of course, if we need to follow federal rules. But right now it's a wait and see moment until further details come out. The next thing that I wanted to do was share a screen, and you can find this information yourself if you would like. This is on the Fear Over Facts segment of the Sanford Health website. And I thought it was very appropriate, and particularly in light of what we're going to talk about today regarding treatment of COVID-19 folks, the COVID-19 hospitalizations. In the Sanford footprint on September 7, 2021, and I believe this is perhaps, 22 Sanford-owned hospitals, there were 135 patients hospitalized. 126 of those in this area here, represented by the red stick figures, 126 of the 135 were unvaccinated. In the ICU within the Sanford footprint, there were 38 in the ICU, 37 of which were unvaccinated folks. Ventilators in the Sanford footprint, 26 patients on vents, 25 of which were unvaccinated patients. So again, as I've mentioned before, the vaccinations are doing their job relative to the acuity of patients. They're not bulletproof in terms of somebody being infected with the virus, but they're clearly keeping people out of the hospital. And when folks are in the hospital, they're clearly lowering the acuity level of those patients. So again, you can refute a lot of different things about the vaccine, but this is hard stuff to refute when this is actually boots on the ground kind of information. So I wanted to share that with you. And again, you can check that out at Sanford Health as well. Okay, so right now I'm gonna give you a little bit of an astronomy analogy as an introduction into our discussion for today. But this whole study of that we've gone through recently with COVID is like studying the galaxy with a Walmart telescope. It kind of shows the stars and planets, but not always clear enough to track their progress through space and time. And meanwhile, we hope to get to some point where we have a chance to use the Hubble telescope. And I thought that sort of summed it up right now. We can still see stuff, we can experience stuff. We know a lot more stuff than we did 18 months ago. But let's talk about exactly where we are today in the treatment world. And let's start first of all by talking about the role of the clinical pharmacist. Can Randi and Amy, you guys kind of fill us in on what a clinical pharmacist does?
So both of us went to school to get our pharmacist degree. We graduated with our doctorate in pharmacy, and then we both did residencies with a little bit extra training, really really for us, focused in what we call ambulatory care or primary care. So we're here to help both patients and providers with medication-related issues. One of the large things we do is blood thinner management here at the clinic. And then on the flip side, when we're not doing that, we're doing a lot of assistance for providers, whether it be helping them get medications approved, or if they're struggling meeting certain guideline goals and they're wondering what meds could help them get to those goals, we can help them with that. And then on the patient side, if the patient calls in and they're having a hard time, whether it be affording medications, access to medications, or side effects to medications, we can kind of try help manage those things to help them get to their goals, whether it be get to their goal blood pressure, get to their goal diabetes, A1C level, things like that. So really, in a nutshell, we're here to help both patients and providers with medication-related concerns.
Great, thank you. Dr. Laird, could you talk a little bit about how the role of the clinical pharmacist fits in with our structure, and maybe more specifically how Amy and Randi fit into that?
Absolutely. So I often talk about the fact when we first started out, we looked at this situation and said, my goodness, how do we use these people? And now our biggest fear is how in the world would we ever get along without them? They are truly part of our team. You've heard me or maybe read where I've alluded to how rapidly things are changing in medicine, and that continues to speed up. Sometime in 2020, we hit the mark where every 50 days, the total knowledge in medicine and in science doubles. So trying to keep up with that is impossible as an individual, and it takes a team to be able to do that. And these folks help us greatly, particularly in the area of therapeutics, in understanding what is the latest thinking. Yes, there's tons of new studies coming out every day. We as providers do not have time to digest each and every one of them, and nobody has time to digest each and every one of them. But those that are clinically salient to us or that are important, Amy and Randi help us understand those. They have excellent training in understanding the studies, looking at the strengths and the weaknesses, and also helping us understand what may be the best medication to choose from the individual patient to the individual disease. So they are truly an extension that their phone rings frequently, their door gets knocked on often. Hey, what about this? This looks like the right idea for me. Do you agree with that? They are integral to the function of our clinic and to the function day to day for our practitioners.
Great, thank you, Dr. Laird, for sharing that. So we're going to turn to Randi and Amy a little bit, and I think you have a screen that you're going to share with us right away. And the first thing that we're going to talk about today are current recommended inpatient treatments. Does that coincide with your first screen?
Yep, you got it.
All right, could you lead us through inpatient treatments available today?
Yes, so as of now, and this changes a lot, and we were kind of wondering, yeah, what has changed? Where are we at right now? So for inpatient, for our patients with COVID who need to be in the hospital, this first column that's highlighted yellow, that is what's recommended. These are our best tools right now. Steroids are a big one. If we have patients who need oxygen or their oxygen levels are a little low, we are going to use steroids. And we really don't use those unless you need oxygen, because steroids blunt your immune system. So if you're in the early parts of COVID, we don't want to blunt your immune system. We want it to work and to fight this virus. But if it gets to the point where it's overwhelmed and there's inflammation, then we use steroids. And we have good evidence that that really helps. So that's a big tool we use. Another medicine is called remdesivir, and this is an antiviral. So it's really just trying to get you exposed to less of the COVID virus. So if we have patients who need oxygen, we're going to use that too. And that's a treatment that was, developed during this pandemic. So Another big thing we have found with COVID in these 18 months is that it causes a lot of blood clots. And it causes clots in lungs and in your legs, and it's just a characteristic of this virus. So we now know to help our patients, we got to get them on blood thinners. So giving them anticoagulants is a really big part of protecting them from those clots and what they can do. And then those last medicines there at the bottom, these are medicines that basically fight inflammation. So they're very specific to the COVID virus and what it does to your body, and it fights that inflammation. But really, these work best in people who are very sick and usually on the ventilator. So we don't have a lot of those patients here. If we have someone that sick, we are transferring them to a bigger institution. So they're recommended, there are options, but we are not really using those here. But the top 3 there, we are using. And then you can see these other columns are medicines that we don't use anymore or that we're just not sure about. So insufficient evidence, we just don't know enough yet about ivermectin. You've probably seen stuff on social media, online, or heard people talking about it. And we just don't know yet. There's a lot of studies out there, and there's some that show negative results and a lot that show positive results. But most of these studies are just not well designed. And if they're not well designed, you just can't trust them, and you can't apply them to your patients here and to know what's really going to happen. So we're at a stage where we just don't know. Ivermectin might work. We just don't know yet. We need bigger trials, better designed, to really see, does this have a benefit or not? And at this point, I know we have some treatments, but it's not a lot. So I can understand if some people want to try these things, and I don't fault people for that. And I think you just need to be careful. There's a lot of unknowns, and at a regular dose of ivermectin is very safe. The side effects are very mild. So if we had, providers or patients that decided together they wanted to try this treatment, I think if you did a usual dose, you could feel pretty good about that safety wise. And there's just a lot of unknowns, and especially I've seen reports in cases where they're using very high dose, and we've just never used that high dose in people before, and we don't really know what it's going to do. So I'm hopeful to see more in the future. We want to see more evidence, and we're waiting, and studies are being done. So we're waiting for results. And then that last column, recommended against use. These are ones we initially had hope for, interest in. We did studies, and the studies have really come back pretty clearly that the convalescent plasma, so that's plasma from people who have had COVID and recovered, and then we give that to people fighting the infection. We've really found that's ineffective. It does not help. And then same thing with hydroxychloroquine. And then I have plus minus azithromycin, that's an antibiotic. So initially, again, we had interest in this medicine, but we did studies, and they really came out showing it doesn't help. And if anything, it caused more side effects, especially cardiac heart side effects. So that is kind of the rundown of where we're at for inpatient treatments. And I'm going to show you outpatient treatments. So people who have COVID, who are sick, but not sick enough to be in the hospital. And our options in that first column are really these 2 medicines, Regeneron and sotrovimab. These are monoclonal antibodies. So they bind to this spike protein that COVID uses to get into your cells. And it prevents them from getting in your cells, and it also kind of flags it for your body to go destroy it and get rid of it. So really what it's doing is you're just getting exposed to less of the virus. And these are available. We're using them. We have them here. We have criteria we have to follow for who qualifies for them, because these are, authorized under this emergency use. So we follow that criteria, and it depends on like age and what other health problems you have. So we go by that, but we are using these for patients who have COVID and we're worried they're going to progress to a more severe case. And like I said before, we just don't know enough yet about ivermectin. We have another medicine called fluvoxamine. It's another really old, cheap medicine. And there's some interest in that also. Some really early studies are showing maybe some benefit, but we need to do bigger studies so we can really see the true effect. And then this last column, recommended against use, again, hydroxychloroquine, like I said before, for outpatient use, same thing. We've done the studies. It's not effective and it's causing more side effects. So we're not using that. And then this other medicine, this BAM medicine, that is a monoclonal, just like the Regeneron and the sotrovimab in that first column. But we are not using that anymore because of the new variants of COVID that are out there are resistant to it. So we used to use it and we no longer use it. We're adapting to what's out there, what variants are out there, and we're using the treatments that work. So that's kind of a rundown of inpatient and outpatient treatment options as of today.
Yeah, and thank you very much. Dr. Laird, I don't know if you have any follow-up to the ivermectin, hydroxychloroquine, or anything else. Is there any follow-up from your perspective?
Yeah, I think a couple things. Number one, which the screen is up now, I wanted to emphasize that the reason that we have more things available inpatient is obviously because you're sicker. You wouldn't be in the hospital if it was mild. And again, fortunately for so many people, COVID turns out to be a mild or a moderately severe cold and doesn't wind them up in the hospital. And we're very, very grateful for that. And there, in those cases, we really don't want to throw anything at it because the risk that you may have a side effect from the medication may outweigh any benefit that you get from it. And for that reason, we try to carefully weigh the benefits of a medication versus the risk of a medication. That's not easy to do. You don't always get to foresee what complications could occur either because of the illness or because of giving a medicine, but you try to do your best to weigh those two and make that intelligent decision. And even oxygen has its side effects. So everything we do, we have to constantly put on the scale and go, do I believe overall this is going to give more good? Or do I believe overall it's going to give more harm? And then decide on whether we need to go forward with it. That is part of why it's so individual, and what may be right for you one day may not be the right thing to give you the next day based upon treatment and where your disease is with this particular illness. So that is why inpatient treatments differ from outpatient treatments, why we wouldn't do the same thing, and why honestly there's less treatment for outpatient because most people won't need that. For those outpatient treatments, particularly the ones we talked about that are the antibodies, those have been somewhat restricted to people that are at higher risk because of how much there's available. And again, we don't want to cause problems unless we believe that the benefit would outweigh any complications. So again, we restrict them to areas where we feel they would be most helpful. I do want to make just a comment on ivermectin and the difficulty and why I appreciate Randi and Amy so much in their help. There are lots of studies on ivermectin, but most of them are small. A lot of them were not done very well, which means you may get a false impression that it's helpful or that it's not helpful. And therefore, being able to look through the study, understand whether it was well done, understand whether it has the power to predict what it does is very helpful. And they help us decide that. And so we would love it if there was a cheap medication we could give to people and rely on that we aren't causing more harm than help. But we do have to have a standard to push us across to do that so that we don't give things too early and cause problems. And to that, I just want to address, and I apologize, I'm being a little long-winded now, but with the hydroxychloroquine scenario, that early on, we did use it. It was talked about and looked at and studied. But personally, I did see problems. We needed to monitor people on heart monitors with it. It's a medication I have personally taken to prevent malaria while we were in Africa, but we knew there that that medication could have complications. And unfortunately for people that took it in higher doses often caused complications. And we were using it at a higher dose than you would for preventing malaria. So once we got into that area, we were concerned about the heart complications. And indeed, we saw that we had to cut back and stop it in cases because of that. And given the fact that it did not really pan out to give that much help when we got it into good studies, we felt we needed to stop using it because we were probably putting more harm than good that we didn't know up front when we started with that. And so as we learn, we have to change and adapt, as Amy and Randi alluded to.
Thanks, Dr. Laird, and thank you, Randi and Amy, for following through with that. And again, I think it's important that each patient presents a unique set of issues going on. And if you feel particularly that ivermectin, as an example, is your drug of choice, we will work with you in terms of an appropriate dose. Again, but you need to be clear where we're coming from at this point also. So Randi and Amy, I believe you had one more graph to talk about outside of treatment. Do you want to talk about prevention a little bit?
And so prevention is key. I mean, if you don't get COVID, you don't get sick from COVID. So what can we do to prevent getting COVID? Obviously, things have been talked about: masking, social distancing, putting barriers between people. All those things have been studied, and yes, they probably are effective. But we also weigh, what you feel comfortable doing. So one thing before we get into vaccination is something that Marty's touched on quite a few times, is just making sure you stay healthy. Go to your wellness visits, keep your blood pressure controlled, keep your diabetes controlled. If you struggle with weight, try stay physically active. The healthier you are going into something, the better chance you have at doing well if you were to get COVID or get any sort of virus, not just COVID. Being healthy up front certainly helps. We have, seen some studies out there with vitamin D, vitamin C, zinc, some of those things. A lot of those things are available over the counter. As with a lot of other medications, the jury's kind of still out. Does it help? We don't know 100%. It might help, but just going back to being healthy, having healthy levels of vitamin D is a good thing. So if you have low vitamin D, you may be already on a supplement. And if you have a normal level, that's great. I think the next thing that we probably just want to talk about quickly is the vaccine. We do have a vaccine that's out there. It's been widely used. Over 360 million doses have been given in the US, which is a lot of doses, and it's being monitored very closely. Really, any sort of side effects we present, we give that information to the FDA. The FDA watches for any sort of side effects. And so we know that it's being watched very closely. And we also know that it is very safe and it is very effective. Initially, we saw greater than 90% effectiveness with the mRNA vaccines, which is Moderna and Pfizer, and more than 70% effectiveness with Johnson & Johnson. Now we have seen a little bit of dip in efficacy with these new variants like the Delta variant. But what's key is we still have very good efficacy against severe illness and hospitalizations. So no one wants to get sick, no one wants to get COVID, but we really, really do want to prevent people having to be hospitalized, people being ventilated, and people ultimately dying from COVID. And so that efficacy is still very good, and that's a good thing. So, we still have vaccines available if people want them. They just have to call the clinic and we can get them vaccinated. Just a quick touch on safety if people are concerned. It has been well studied, and there are some rare side effects. there are rare cases of anaphylaxis with really the COVID vaccines, but any vaccine. They have been studying this TTS, or thrombosis with thrombocytopenia syndrome, mostly with the Johnson & Johnson vaccine. They've kind of been watching that. And then the myocarditis or pericarditis have been reported, and they're being monitored. But just to put that in perspective, they're also monitoring myocarditis if you get COVID. And the chance of getting myocarditis if you get COVID is 6 times higher than if you get the that versus the vaccine having that side effect. So still COVID is much more dangerous when you look at numbers and studies and things like that. Briefly, there are vaccine boosters. I know this is kind of a hot topic right now. We don't have vaccine boosters for everyone yet. We haven't gotten the green light to do that yet, but we have gotten the green light to do it for immunocompromised patients. So patients that are transplant patients, or if they're on chemo, if they're on really high dose steroids, not just a general steroid, but really higher dose steroids, they would probably qualify for a booster shot. So we do have those available. And then that same monoclonal antibody that Amy talked about for outpatient treatment, Regeneron, is available what we call for post-exposure prophylaxis. So someone who is at high risk, like an immunocompromised patient, if they were exposed to COVID, they haven't gotten COVID, and they're not testing positive for COVID, we could give them this Regeneron in hopes to prevent them getting COVID or getting serious infection. So that is an option for very specific people that are high risk, that are immunocompromised. And we a lot of times will play a role in if they qualify for that based on the FDA's guidance that we have. So that's just kind of a little plug on prevention and things that you can do to try prevent getting COVID, because if you don't get it, then you don't get sick from it. So.
Excellent. So, thank you guys for being with us today. Thank you for sharing your expertise with us. I just want to summarize a couple things, and that is keep your engine tuned, and Randi said that, and the healthier we are, the healthier our bodies are, the more able they are to fight off any kind of virus, not just the COVID virus. And we've been saying that for a long, long time. We're also still strongly recommending the vaccine. Just again, in a summary format here, it clearly shows that it diminishes the likelihood of you getting seriously ill, the likelihood of you needing to be hospitalized, and it is just, in our opinion, clearly the right thing to do. So again, thank you guys. Thank you, Dr. Laird, for joining us today. Really appreciate your expertise for everything that you do, not only for Orange City Area Health System, but for all of our patients. You're all greatly appreciated. Thank you very much.
Thank you.
And I just want to end with a statement that I came across the other day, and I thought it was appropriate. The risk of COVID is low enough to live your life, high enough to be careful. And so I still think, we go back to that, keep your engine tuned, get vaccinated, get outside a little bit and enjoy things, right? And we'll continue to try to thread that needle between all of these things, but greatly appreciate all of you out there for joining us today. And again, thanks to Amy, Randi, and Dr. Laird. Thank you all.
Thank you.